Welcome back. And today's topic, type 1 hypersensitivity. So let us dive into it. So, as you know, the hallmark of type 1 hypersensitivity that it is immediate, it is humoral IgE mediated. The main effect that we desire is mast cell degranulation to have the effects. So let us understand this first. So just shift your focus to this diagram. So whenever first time any allergen comes into our body, it encounters the first line of defense, that is APC, that is antigen presenting cells, or also known as phagocytes or macrophages, or neutrophils. But APCs are usually macrophages. So allergens, they are usually taken up by these antigen presenting cells. What does these antigen presenting cells do? They engulf it, they phagocytose it, cut it into smaller pieces, and these APCs have a receptors on them. These are known as MHC2 receptors. And in these MHC2 receptors groove, you present this allergens representative peptide. And APC MHC2 can only bind with CD4 receptor. So it goes and attaches to CD4 receptor, which is on CD4 T cell, and it stimulates this CD4 T cell. CD4 T cell, which is a T helper cell, will analyze this allergen peptide molecule and understands that it is a special type of molecule which requires special treatment. So it will stimulate itself, and it is differentiated into Th2 cell. Now, to get differentiated to Th2 cell, it requires interleukin 4. So that is secreted by these activated cells, and all the T helper cells, they get converted to Th2 cells. Now, these Th2 cells now then go to the B cell. Okay, and this they call this B cell to convert into plasma cells along with forming a memory cell, and they tell them that okay, this is the molecule that we have received from APC, and it is an allergen molecule, and it requires antibody, and your IgM will not do the justice. You have to produce IgE. So but by default, B cell will convert into plasma cell, and the initial response is always IgM. But B cells and plasma cells know that this is an allergen because this T helper cells have told them so. So what they do, they produce IgE. They class switch from IgM to IgE. Now these IgE are very specific against this allergen, but here they do not do anything. So first time exposure, when you get first time allergen exposure, there is no manifestation, there is no signs and symptom, and because this antibody forming process takes time, and this newly formed IgE, they go and find mast cells, and mast cells have receptors, Fc receptors, against this IgE, and they go and sit there on those Fc receptors. So all the mast cells now they are coated with this IgE against this allergen. So this is the first contact. If ever in your life you are re-exposed to that allergen again, so re-exposure to that allergen, if it is there, then these mast cells now they are in respiratory lining as well as other epithelial linings which are there, and now this allergen will directly come into contact with these IgE molecules which are sitting over these mast cells. But we have to understand that it requires dimerization. That means one allergen has to bind to two IgE molecules antigen binding sites, that is known as dimerization of IgE. And once dimerization of IgE is there, it uh, asks mast cell to degranulate, and mast cells are rich in granules which are having mediators like histamine, heparin, serotonin, various chemotactic factors for eosinophil and neutrophil, various protease enzyme, and they will just release that. So degranulation of mast cell will happen. These are known as primary mediators, which are already there in granules. And the secondary mediators, it also asks them to form them and release them. So platelet activating factors, leukotriene, prostaglandins, bradykinin, and various cytokines are also formed. And the secondary mediators are also degranulated. And all these molecules, all these chemical mediators, they perform five functions. First, they will cause smooth muscle constriction. They will cause blood vessel dilation and increase capillary permeability. They cause platelet degranulation and platelet clumping. And sensory nerve endings are stimulated. And eosinophil chemotaxis as well as neutrophil chemotaxis is there. Now, this response could be localized, it could be generalized. If it is localized response, then you get atopic reactions. Uh, Bronchial asthma is a classical example of the localized type 1 hypersensitivity. Hay fever is a classical example of localized hypersensitivity. So, hay fever is basically your exposure to airborne allergens with conjunctiva and nasal mucosa, which leads to watering from eyes and sneezing and coughing. Bronchial asthma is basically this allergen they expose to lower respiratory mucosa, resulting in constriction of bronchial smooth muscles. So, bronchoconstriction will lead to breathlessness and attacks of that. Food allergies, they are also examples of this localized type 1 uh, hypersensitivity, which is known as atopy or localized anaphylaxis. Atopic dermatitis, which is known as allergic eczema, which is red skin eruptions are there. Various drug allergies like penicillin and sulfonamide, so drug rashes are also example of type 1 hypersensitivity. But the main thing that we fear is if this response is generalized, it is happening everywhere in the body. So it is a systemic or generalized anaphylaxis. Then it results into anaphylactic shock. Person have severe dyspnea, hypotension, and vascular collapse. Mainly penicillin uh, is a culprit of inducing this type of anaphylactic shock. Sometimes bee sting is also a culprit. The only drug of choice we have for anaphylaxis is epinephrine or adrenaline. For localized, we can use hypersensitization as well as monoclonal antibodies against IgE. That is possible. In prevention, we should avoid contact with known allergens that is there, and other supportive drugs, especially in anaphylactic shock, along is antihistaminic, cortisone, theophylline, and cromolyn sodium. But the main drug of choice will remain always epinephrine. So, how we can detect this reaction? So there is a skin prick test, which is known as PK reaction. Here, small amounts of suspected allergens are introduced at different skin sites by intradermal injection or by superficial scratching. If person is already exposed to this antigen, you will see local veil and flare response within 30 minutes at inoculation site. It is relatively inexpensive and it allows screening of large number of antigens on one go, but sometimes it sensitizes individual to new allergens and may induce late phase reaction or systemic anaphylaxis later on. So that is the thing. Or you can measure IgE levels, total as well as allergen specific, using various immunoassays like uh, radioallergen, allergo sorbent test, or autoimmune immunoassay system, or fluorescent assay systems, which are now available. So this is about type 1 hypersensitivity, its mechanism, uh, what are the different types, what are the main mediators, how you can diagnose it, how you can treat it. So I hope the mechanism is clear to you. So stay tuned for next video in which we will talk about type 2 hypersensitivity.